Good morning, ladies and gentlemen. This is the video for day 6, the beginning of the Function of the Heart, Chapter 17 in the Human Body and Health and Illness textbook. So if you've got your course schedule out, you'll see that on day 6, we're looking at the beginning of the functions of the heart, vocabularies, bradycardia, cardiac cycle, cardiac output, chronotrophic effect, diastole, dromotropic effect, heart rate, inotropic effect, parasympatholytic, stroke volume. We're going to be going over the previous day's reading from page 298 through 303, and we're going to do that right now. So the graphics you should have uploaded, and I think I've got them on day 7 instead of day 6. I'll have to move that. If we look at the graphics as we pull them up here, they are the same as they are on page 299 in the textbook. So to start off with, the coordinated and adaptable pump, dealing with the cardiac cycle. So the cardiac cycle is that sequence of events essentially that take place through the total contraction and then relaxation of the heart chambers. A term for contraction of the heart muscle or myocardium is called systole. And the relaxation of that myocardial tissue is called diastole. Okay, these two, systole and diastole, are also synonymous, and they're used. They're the root words to describe blood pressure: systolic blood pressure and diastolic, the two numbers that you get. And we'll be looking at blood pressure actually in the near future here. But a systolic refers to the pressure exerted by the heart during the systole or contraction phase, and diastole is the residual pressure in the blood or the circulatory vessels during cardiac relaxation. If we look at the diagrams, we see that there are two phases of systole and two phases of diastole. One is atrial systole and ventricular systole. The others are atrial diastole and ventricular diastole. We can see these on our electrocardiogram, as we talked about previously, by the deflections. The P wave is the atrial systole, the QRS complex is the ventricular systole, and the ventricular diastole is described by the P wave at the end. Atrial diastole, the relaxation takes place, but it's buried in the QRS complex there. So during atrial systole, the contraction of the atrium is stimulated by the sinoatrial node. That the heart is full of blood, but during atrial systole, more blood is forced down into the ventricles to actually stretch them a little bit. Now, depending on the amount of cardiovascular stress the body is under, more blood will be pushed into the ventricles and returned to the heart and so on as necessary. But it's not an acute volume taken from the atrium put into the ventricle, from the ventricle out to the body. It's not like a set volume from the atrium to the ventricle. When the atrium contracts, the ventricles are already full of blood. The atriums squeeze and force a little more into the ventricles. And we'll talk about that stretching of the ventricular myocardium in a little bit here as well. During that atrial systole, that pressure from the atriums contracting forces blood through the two cuspid valves down into the ventricles. When the ventricles are stretched and they're full, and the impulse reaches the left and right bundle branches and the Purkinje fibers, the ventricles contract at the same time. That back pressure causes the cuspid valves between the atriums and the ventricles to close, and the semilunar valves between the ventricles and the pulmonary and aortic artery there to open up and allow the blood to be pushed downrange. During ventricular diastole, the relaxation phase, those semilunar valves close because the pressure in the aorta and the pulmonary artery are greater than the pressure in the ventricles. Therefore, the semilunar valves close, preventing retrograde flow. The term retrograde flow refers to reverse flow. Prevents that retrograde flow, allows the cuspid valves to reopen, and blood pressure from the superior and inferior vena cava flow into the atrium through the bicuspid valve into the right ventricle, and the same thing from the pulmonary veins into the left atrium and left ventricle, and the whole phase repeats itself. Now, the whole cardiac cycle lasts just less than 1 second, about 0.8 of a second. We have about 70 of these at rest. The average person has 70 cardiac cycles a minute. Essentially, it's your heart rate. Okay? More cardiovascularly fit people perhaps will have lower heart rates. Others, depending on their fitness level and perhaps issues with their heart, may have faster heart rates. I've had students in class that have taken their heart rate and they're 45, 50 beats a minute. I've had other students in class who had a resting heart rate of anywhere from 105 to 120 beats a minute. That student actually was actually waiting for some medical consultation because she did have an irregular heart rate as well. Okay, flipping the page over to 300, 301. Now, how does this all happen? Well, there is what's called the autonomic control of the heart. Our heart takes care of everything by itself. Really, we don't think about doing this. The autonomic nervous system takes care of speeding up, slowing down the heart as we need. There are essentially three control systems that affect the heart in terms of innervation. The heart is innervated in the sinoatrial node, the atrioventricular node, and the myocardial fibers of the ventricle by the sympathetic nervous system. Now, the sympathetic nervous system you can think of as your gas pedal. The sympathetic nervous system, you've all felt it happen. If you've ever felt an adrenaline rush, you get scared, you get excited about something, you're sitting in class and this hottie comes and sits next to you. Yeah, you all know what I'm talking about. You start to sweat a little bit, you feel your heart pounding, your breath starts to kind of get a little ragged, and so on. That's the sympathetic nervous system. It's also been referred to as the fight or flight syndrome. Our bodies have evolved this method of basically self-preservation. You get into a dangerous situation, like you're walking down the street after babysitting one night, and some guy jumps out of an alley and wants to take what you've got. Your heart speeds up, and a whole cascade series of events take place physiologically that we really have no control over, that essentially prepares us to either fight with this person or thing, or run away. It's a self-preservation instinct. Now, in terms of the myocardium, how it works, the sympathetic nervous system is innervated into the sinoatrial node. This speeds up the rate at which the sinoatrial node fires impulses. It will increase what's called the chronotrophic effect on the heart. It has a positive chronotrophic effect. It speeds up the heart rate. So instead of beating at 70 beats a minute, it might be up to 120, 130, depending on what's going on. The second effect that the sympathetic nervous system has is on the atrioventricular node. That's our little yield sign, remember? The little yield sign pauses that signal to allow the atriums to fully undergo their depolarization and contraction, filling up the ventricles and allowing them to stretch. What the sympathetic nervous system is, it shortens that time that the electrical impulse is paused at the atrioventricular node. It allows that electrical signal to pass through just a little quicker. And the reason for that is we don't want that pause that long if we're increasing the heart rate. The third effect, that effect on the atrioventricular node is a positive dromotrophic effect. The third effect that the sympathetic nervous system has on the heart is the innervation directly to the myocardial tissues of the ventricles. The innervation of the myocardium actually causes the actin and myosin myofibrils in the myocardial tissues to contract harder. So they will actually squeeze a lot harder and cause the ventricular contraction to expel more blood. It increases the output, which is what all of these effects do ultimately. They increase cardiac output. The sympathetic innervation into the ventricular myocardium is called a positive inotrophic effect. And the way I remember that is it causes the ventricles to squeeze inward harder, and it's an inotrophic effect. So the sympathetic is innervated into the sinoatrial, atrioventricular, and myocardial fibers, a positive chronotrophic effect, dromotrophic effect, and inotrophic effect. Okay, as the sympathetic is your gas pedal, the opposite to that is the parasympathetic. The parasympathetic nervous system is your brake. You can actually elicit a parasympathetic response. You've all done it. You get all excited, you get wound up about an exam. You're told to just close your eyes, take a deep breath, and relax. What you're doing there is you're eliciting a parasympathetic response. The primary nerve for the parasympathetic nervous system is called the vagus nerve, and it it also has to do with the digestive system and blood pressure, so we're not even going to get into that right now. But your parasympathetic is your brake pedal. It slows things down. It's only innervated into two places in the myocardium. First of all, the sinoatrial node, where it slows the heart rate down. So you have a negative chronotrophic effect when the parasympathetic nervous system kicks in. In the atrioventricular node, it extends that pause where the electrical signal is paused at the atrioventricular node, and that is a negative dromotrophic effect. It is not innervated into the ventricles. So this is why after you've had an adrenaline rush, you'll find that your heart is slowed down and you're starting to relax a bit, but it feels like your heart is still trying to pound out of your chest, trying to jump out of your chest, because there's still the residual sympathetic stimulation of the ventricles to contract harder. Okay, so we have a negative parasympathetic, a negative chronotrophic effect on the sinoatrial and a negative dromotrophic effect on the atrioventricular. There is no innervation into the ventricles by the parasympathetic, so it just keeps on contracting until the stimulus from the sympathetic nervous system is gone. Now, there are a couple of chemicals, the chemicals that our body produces to cause these effects. First of all, norepinephrine. Epinephrine and norepinephrine, people often call it adrenaline. Adrenaline is produced by the adrenal glands on top of our kidneys. This stimulates the sympathetic nervous system. The parasympathetic is acetylcholine. Acetylcholine is the chemical, the neurotransmitter that is produced to elicit a parasympathetic response. Now, the sympathetic nervous system can be stimulated by not only the fight or flight syndrome, but other disease states or stress states that our bodies undergo. When you're sick, your body is working harder to fight the disease. It secretes a small amount of epinephrine, norepinephrine, to stimulate a higher cardiac output to address the need. When you go to phys ed and you start to jog around, your heart speeds up in response to the increased demand that your muscles have for oxygen, for nutrients. So the body recognizes that, and it secretes some epinephrine. We don't get the big surge of adrenaline that we do in a fight or flight response, but that gas pedal still, our body still steps on that sympathetic gas pedal gently to speed up our heart to the point where we need it to be sped up at. Okay. Other situations, circulatory shock, disease states. These can be caused. These can cause excess sympathetic firing. Excess sympathetic activity can often cause what are called tachydysrhythmias or tachdysrhythmias. The prefix tach refers to fast or speedy. Dysrhythmia is pretty self-explanatory. It's an unusual rhythm. It's not a nice consistent rhythm with the heart. Now, there's an extensive selection of information there about sympathomimetics, sympatholytics, et cetera, et cetera. We're not really too worried about the different medications or drugs that affect the sympathetic and parasympathetic at this level. Just knowing that you understand the sympathetic and parasympathetic nervous system, and as it comes down to the heart or the myocardium, is an advanced concept here for you guys. So the next little concept we're going to talk about is cardiac output. Well, cardiac output is the amount of blood that the heart pushes out with each stroke. Okay, stroke volume is how much the heart ejects downrange from itself every time it contracts. We multiply that by the heart rate, we end up with cardiac output. So if I said the cardiac output is 5,000 milliliters, that means they're putting out 5,000 milliliters or 5 liters in 1 minute of cardiac cycles. Now, on average, like I said, 72 beats a minute, resting heart rate. If we speed that heart rate up, keeping everything the same, we're obviously going to increase cardiac output over that period. If we increased our heart rate to 140 beats a minute, in theory, we would think we would be able to double the cardiac output. But if we increase the speed that the contraction or the signal goes across the atrioventricular node, and we increase the contractile force of the ventricles, we can increase what's called the ejection fraction, or the amount of blood ejected as compared to how much is in the heart at once. If we increase that ejection fraction, we increase the efficiency of the heart. It ejects more blood per stroke. If we have each stroke happening faster, we increase the cardiac output a lot more drastically. Now, there's a couple of other factors. Gender, women have slightly faster heart rates than men, so they typically have a higher cardiac output at rest. Age, The younger the person is, the faster their heart rate, and vice versa. Infant's heart rate, for example, is 120 beats. Fetal heart rate, 140 to 160 beats a minute. Exercise. Exercise also increases your heart rate because of the demand. Stimulation of autonomic nerves. Hormonal influences. If you're taking medication, anything that has pseudoephedrine or ephedrine in it, yeah, that's a sympathomimetic. It stimulates the sympathetic nervous system. Thyroid hormones increase heart rate as well. Pathology in certain disease states, as well as medication that can affect heart rate, like digoxin, for example. A patient that has what's called an irregularly irregular heart rate, or atrial fibrillation, will take digoxin because instead of just having the sinoatrial node firing the whole heart, patients that have atrial fibrillation will have what's called an irritable focus, and they'll have another little spot on the heart that will start to twitch. Kind of like you get the easiest comparison that that's been explained to me is that you get that little twitch in the corner of your eye. The same kind of thing happens in a different part of the atrium, but it stimulates a whole contraction or a whole cardiac cycle. So rather than the heart just listening to the sinoatrial node, there's another pacemaker that's trying to take over, or that's just causing the heart to twitch. So the heart undergoes an irregularly irregular heart rate. Digoxin will slow this down and decrease the stimulus of the heart to contract. Now, I spoke about stroke volume, and this is essentially the amount of blood ejected by the ventricles per beat. On average, it's about 60 to 80 milliliters per beat. At rest, the ventricles pump out only about 67% of the blood in the ventricles, so we've still got more left in there. As we increase the contractility with that positive inotropic effect, we can increase that percentage. Cardiovascular fitness also plays a role in how efficient a patient's heart is. Now, you would think that someone who has a high heart rate all the time would have a really strong heart and it would be really good. Well, that's not necessarily true. In some certain disease states, as in older people with atherosclerosis or a buildup of plaque in the arteries, making the arteries smaller, the heart has to work harder all the time to push the blood through there. If the heart has to work hard all the time, it undergoes what's called a hypertrophy. And that's what what bodybuilders want to have happen to their skeletal muscles, is to get larger. A constant stress on the heart will cause an enlargement of the heart muscle, and that enlargement of the heart muscle decreases its contractility. It can't contract as well as it used to. It's not as flexible either, so it won't stretch as well as it used to. So you actually decrease the efficiency when you get a larger heart muscle. And this leads to a condition called heart failure. And we're going to talk about right and left-sided heart failure later on down the road here. For right now, we want to look at how to change stroke volume, page 302, 303, fairly straightforward. First of all, we have the positive inotropic, chronotropic, and dromotrophic effects on the heart, where we talked about the contractile myofibrils contracting harder because of the sympathetic stimulation. Contracting faster because of the positive chronotropic effect, and the dromotrophic helping that positive chronotropic effect. There's also one other phase called Starling's law of the heart. And essentially what it refers to is the further the ventricular myocardial fibers are stretched, the harder they will contract. Okay, so it's almost like a inversely proportional relationship. Stretch increases the force of contraction, which in turn increases stroke volume. So what happens when we have an increased demand on our circulatory system, as in say we're running in the gym, there's an increase in venous return to the heart. The veins return a higher volume of blood to the heart, thereby increasing the volume returning to the atriums and the ventricles. That high venous return stretches the right ventricle, and then as the right atrium contracts, it stretches that right ventricle even more and causes the right ventricle to eject that blood out to the lungs at a higher stroke volume. So instead of 67%, you may be increased to 78 or maybe even 80%. And Olympic level athletes can increase that even higher. That venous return pushed out to the lungs for reoxygenation also comes back to the right, or probably the left atrium and ventricle, where the return blood flow is increased. It stretches the ventricle and the atrium. And then when the left atrium contracts, it stretches that left ventricle even further, which causes a harder contraction. So this Starling's law of the heart relates to stretching of the myocardial fibers and the increase in force of contraction, which increases stroke volume, increasing cardiac output ultimately, and getting more blood circulating. So Changing cardiac output by heart rhythm and stroke volume, yada yada. We are done at the end of page 303. Heart Talk, Part B. We are going to talk about that tomorrow, and that's ultimately what the changing of the volumes and from the changing of the stroke volume and increasing cardiac output leads to here. So, end of day 6, you guys have page 186 in the old Human Body and Health and Illness Study Guide to look at, please, and matching. And then read tomorrow, page 303 through 309. That's looking at Heart Talk. We'll review the inotrophic, dromotrophic, and chronotrophic effect. There is a section, Heart Talk receptor language, that you do not need to worry about. That beta adrenergic receptor activation, adrenergic receptor blockade, cholinergic reception, cholinergic blockade. If you want to read it, great. I am not going to have any questions on the exam for that. That is paramedic level. If you want to learn it, go ahead. It's interesting stuff, but it's pretty advanced. Up to page 309, going through part C, the failing heart, when heart can't pump. We'll look at left and right sided heart failure, and that tomorrow is the end of the function of the heart section. So go ahead and get some of that material done. You should have also downloaded and printed off the course, or pardon me, the recipe card mind map assignment. That recipe card mind map assignment is to be done for the end of the program as well, the end of the course, and that's essentially making a mind map or recipe cards or a placemat or any kind of graphic organizer that you like to make to address the topics that are listed in that recipe card mind map assignment. If you like to draw and sketch, do that. If you like point form notes, do that. If you like writing paragraph notes, do that. Whatever works for you. Okay, questions, give me a call. If not, we'll talk to you tomorrow.